All right. Good morning, everyone. Thanks for, or afternoon, I'm sorry, if you're on the East Coast at least. Thanks for joining us today for our webinar on research and policy updates on sickle cell disease. As many of you know, that Juneteenth, June 19th, is also Sickle Cell Disease Awareness Day. And so we want to, leading up to that day, we want to give everyone an update. And we have two great people that are going to talk through this with you. The first is our very own Vice President, Dr. LaTasha Lee. Before joining us at NMQF, she worked with the hematologists and in government space. She worked a lot on public policy programs in that on sickle cell disease. And she continues to work on that right now with us at NMQF. And then we have Dr. Chawla, who is from Bluebird Bio, is one of the experts. I spoke to her before the call, and I was like, oh, it seems like every time we're talking sickle cell disease, you're the person imparting the knowledge that we all need to hear. So you'll get a medical and clinical perspective, and you'll get like a real world applications of it. So without further ado, I'd like to turn it over to our very own Dr. LaTasha Lee.
Thank you, Brandon. I am going to do the nervous moment of the day and share my screen. It's always that thing where you're like, I hope I do the right thing. So just give me a wink or a heads up if you see my screen. But as Brandon indicated, I'm LaTasha Lee, and I'm Vice President of Social and Clinical Research and Development at NMQF. And I am extremely passionate about sickle cell disease, both from a personal standpoint and a professional standpoint. So, with that, I really want to talk today about research and policy perspectives related to sickle cell disease with Anju. And so, before I introduce her, I really wanted to reiterate what Brandon indicated. June 19th is officially designated as World Sickle Cell Day. And it's basically an international awareness day observed annually with the goal of increasing public knowledge and understanding of sickle cell disease and the challenges experienced by patients and their families and caregivers. Today, I'm joined by Dr. Anju Chawla, Medical Director in Medical Affairs and the U.S. Sickle Cell Disease Lead at Bluebird Bio. She's also a practicing pediatric hematologist, oncologist with 20 years of experience at Hasbro Children's Hospital in Providence, Rhode Island, and also a professor at the Albert Medical School at Brown University. I'll give a full intro a little later. But as indicated, our topic today is in support of World Sickle Cell Day, and this webinar will really focus on research and policy updates related to this devastating disease. Anju, if you don't mind, before I jump into our conversation, I'd like to give our audience a bit of an introduction to sickle cell disease, or SCD 101. Sounds good?
Perfect.
So many people may not know of sickle cell disease, or they did. I sometimes get this. I wear a lot of awareness shirts, especially when I'm traveling, about sickle cell. And people are like, I haven't heard of that in years. I thought it was gone away. But for those who've never heard of it, sickle cell disease, or SCD, is an inherited blood disorder that alters the blood's or the body's ability to have normal red blood cells, which normally are like flexible discs or jelly donuts that easily move through the vasculature. But when one has sickle cell disease, and it's typically a point mutation, so one misspelling of your genetic code, it causes the cells to have this disc or sickle shape. Sickle, for those of you who garden, is a tool that's used in gardening that kind of looks like a half moon. And in this sickled state, these cells become quite hard, sticky. It can cause a number of challenges. So when sickled red blood cells moves through the small blood vessels, they can become blocked and cause inability of the flow of blood through that particular vasculature and cause issues. Anemia is often what we hear about. And as a result, people with sickle cell disease often experience these painful episodes or pain crises that start suddenly and vary in severity, can last for varying length of time. And pain is therefore the leading reason why individuals with sickle cell disease go into the hospital emergency department. In addition to just the morphology of the cells and the lack of the blood to flow, there's additional complications of sickle cell disease, including repeated infections, swelling of the hands and feet. And we'll talk about a little of those in a few slides. So I was really thankful of this slide from a colleague of mine at Johns Hopkins, Dr. Sophie Lanscron, who published the improved survival rate of children with sickle cell disease. For those of you who don't know, this is a genetic inherited disorder, and it used to be a disorder where children were dying in childhood and they weren't reaching adulthood. And so the following graphics actually display that, where you see the childhood rate typically was represented by a high mortality rate. However, we've made advances in the field due to lots of different efforts, whether it's increasing understanding of sickle cell disease by providers, the use of prophylactic treatments such as giving antibiotics to reduce infections, screening programs, the use of disease modifying therapeutics, and we'll talk about curative therapies later with Anju. We've actually increased the survival rate of adults. So, sickle cell disease across the lifespan is a bit challenging. Most of the management of the disease focuses on secondary prevention or treatment. And so, the individual born with sickle cell disease has what we call fetal hemoglobin, and fetal hemoglobin typically drops off at a certain point in a child's early development. So, it's usually around that 6 month time frame that some of the complications begin manifesting, such as hand foot syndrome, infection, and splenic sequestration. Additionally, as they progress through childhood and adolescence, additional things like vaso-occlusive crises or pain episodes, acute chest syndrome, brain injuries such as stroke, and additional things such as priapism, retinopathy, gallstones, skin ulcers, hypertension, insufficiency, and cardiac dysfunction also take place within these individuals, unfortunately. But we'll talk a little later. Andrew has some great news from Bluebird that we'll share briefly on today's call. But we have to realize that sickle cell disease is actually a worldwide disparity. The majority of individuals living with sickle cell disease, I think my picture's not showing up on the slide, apologies. But the majority of individuals are in low income countries. What should be showing is an image from the Peel paper, which shows a cardiogram of the change in projected deaths or cases of sickle cell disease by 2050. And what you can see is that patients residing in high income countries typically are living a little bit lower. And historically, there has been a slow pace of clinical breakthrough. As well as implementation of evidence-based care, which result in this worldwide disparity. So here actually it's showing now is the Peel paper, which shows that there's an increase projected of sickle cell disease by 2050. So it'll be 30% increase. Additionally, you see some of the disparaging and hard hitting data around sickle cell disease globally. And it is a myth that it only affects African Americans and those of African descent. It's basically wherever you saw malaria, you will see this disease. And I think Anju is the expert on sickle, so I'll let her share that. But it's really important to note that in resource poor countries like Africa, and on the continent of Africa and in India, that many children don't survive until adulthood. But let's take a look at the United States. So SCD can lead to lifelong disabilities and reduce the average life expectancy, as we saw. The average life expectancy for individuals with sickle cell disease in the US is in the mid 40s for females and around early 40s for males. And that lifespan is a lot shorter than that of individuals not living with sickle cell disease. In addition, there's a financial cost, which is quite high for sickle cell disease care. And it really does result in high treatment costs, as indicated on the slide. The average person with sickle cell disease who reaches age 45 has an estimated total lifetime healthcare costs of nearly $1 million, and annual costs for children is over $10,000, and for adults over $30,000. And 3/4 of hospital stays involving sickle cell disease had a public payer. And we'll talk about that on the next slide. That's Medicare and Medicare type of, and it's actually documented here. So 25.7% are Medicare covered, and Medicaid is roughly half. the 30-day readmission rate for sickle cell disease is 40% for those adults aged 18 to 34. So, as you know, NMQF is really known for our health indices, and this is a snapshot at our sickle cell disease index, where on the left I'm showing Medicare fee for service, and on the right, Medicaid. Interestingly, and everyone always asks about the geographic distribution, even though it's not only limited to those of African descent, there is a historical view that you see here where a lot of the population really is congregated in the Southeast, and that was due to transatlantic slave trade. And what you're seeing is in the darker reds are the hot spots, basically, of where there's large numbers of individuals living with the disease. And then there's some areas where you see up in the Midwest and out west in California as well. And I think it's really important to note the race and ethnicity demographics that are highlighted at the bottom. It's not all African American representation. You do see some individuals who identify as Caucasian or white, Asian, typically the Indian population, and also Hispanic origin represented. So I really want to highlight sickle cell disease therapeutics. 5 years ago, when I started really embarking upon this as a career, there was only one FDA-approved treatment, and that was hydroxyurea. Now we see a lot of progress. There's several disease modifying therapeutics available for sickle cell disease. We have hydroxyurea, which was 5 years ago really focused in adults, but there was an approval by the FDA for children. We have L-glutamine or Endari, we have crizolizumab or Invecchio, and voxelotor or Oxbryta that have been approved. And we'll talk a little bit about curative therapies. There has been a lot of work over the last several years around stem cell transplantation, and data of 1,000 children with SCD from Brazil, Europe, the United States, Africa, and the Middle East is outlined on this particular graph. And these individuals underwent stem cell transplants from matched sibling donors. And they saw a 3-year overall survival of 94%. But the problem is finding a matched sibling donor, which can be challenging for a number of reasons. But there's promise on the horizon. Gene therapy provides the ability for a patient to serve as their own donor. It utilizes engineered viral vectors to insert a normal copy of the gene that is defective for sickle cell disease. And several patients who've completed the protocol are doing well. And the first patient who was treated in France, as well as those in the US, those trials began in 2015. So with that, I'd like to introduce Dr. Anju Chawla, who is medical director in medical affairs and U.S. sickle cell disease lead at Bluebird Bio. I gave a bit of her intro earlier, but I really would love for her to open up and give a little bit of background, why she's so passionate about sickle cell disease. We've known each other for several years, and I really do consider her a friend. Anju?
Yeah, I torture you enough, don't I? I do have to tell this group how I'm excited that LaTasha has joined you guys. I think she's a phenomenal resource. And of course, because we both have sickle cell disease as one of our main focuses. My journey with sickle cell disease actually started off in med school. I went to med school in the University of Vermont, and there was this one patient who kept coming in who was of African-American descent. He was a young Black male in his mid-20s, and he kept coming in with agony, and he kept coming back over and over and over again. And that's when somebody said, well, he's probably has sickle cell disease. So again, back then, not everybody had newborn screening. They didn't know the diagnosis. And sure enough, the diagnosis was made. And I learned about this rare disease because in Vermont, it's not known to be racially diverse. And so this was this one patient. And I so really got interested in this really rare disease. And, why does it cause so much suffering? So have always been interested in sickle cell as part of my medical career, took care of patients in residency and fellowship, and actually did some of my fellowship training, looking at a mouse model, trying to look at in utero transplantation to see if we could bypass the need for a donor to get mice to be cured of their sickle cell disease. Didn't work, but that's another story for another day. So then we, move on. I've been practicing. I took my first job out at Hasbro Children's Hospital, and from there, I was able to follow and derive their sickle cell program, which at that point was just pediatric. There wasn't an adult component. Again, in the late 90s and early 2000s, people really weren't sure what sickle cell disease were, but it's a disease of children. It wasn't a disease of adults. So really this understanding that this really does happen through a lifetime, and really developing this idea that it's a genetic disease, so it does last an entire lifetime. So you have to think ahead. You can't just say, okay, we're going to fix the problems of today. So newborn screening came through, penicillin prophylaxis. The immunization schedules have improved so much. And that's why we've seen that decrease in childhood mortality from sickle cell disease. It's phenomenal, it's beautiful, and it's wonderful to see. But we still are working on how to ameliorate the suffering that comes with the disease, including those vaso-occlusive episodes and that pain management. So that next step really is, as we've talked about here, is hydroxyurea. Doing transcranial Dopplers or ultrasounds of the head to decrease, to detect who's at risk for stroke and to treat them before the stroke ever happens. So that kind of pediatric point of view. Great presentation. We really do have options that are coming, but they're still not everything they should be. We need to have as many choices as possible where, if you think about like GE reflux disease, there's 50, 100 medications, 5 for sickle, of which it's still very hard to get the newer medications, and many places won't pay for multi-pharmacy, where even though these drugs work in different ways and can ameliorate sickle cell disease in many ways, that they might work better together, and it's not being even supported or even being thought about at that level. And we need to be thinking about that. You can tell, I want to make sure that everybody grows up and doesn't allow sickle cell disease to drive their destiny. It can be a part of them, it can be part of who they are, but it shouldn't drive who they want to be. So these medications would help. Transfusions, we've made progress in transfusions, we've made them safer, we've learned how to do iron chelation to help decrease the amount of iron loading that comes with transfusions and delay problems. But what we're realizing slowly but surely is that these are still not enough. What's happening now is we look at that transition age of patients in sickle cell disease when they go from a pediatric provider to an adult provider. That transition, which we thought was just social, we're realizing, this is actually probably those kids who would have died early on are the ones who are now being saved and are now hitting their teens, early adulthood, and those complications of sickle cell disease are beginning to show their heads now versus in their youth. So that's part of it, but this is such a vulnerable population. And as we know, particularly for minorities, that ability of coverage for healthcare in the adult population is so much less than it is for the pediatric one. So you've got somebody who has had hopefully phenomenal care. 94% of children with sickle cell disease are cared for in a facility where they have a sickle cell disease expert and at least several specialists around them that can help them drive their care. In the adult world, those resources just aren't there. There's a few key places where those kind of systems exist, where there's a solid transition program. And even in those places, it's not very solidified. So this idea of we need to transition, and then we need somebody to take care of these adult patients with sickle cell disease with compassion, with understanding, to understand the pain that they're in, treat the pain, work on that trust, work on that relationship, and then talk about what we can do to prevent further problems. So all of those things need to come into play. And this is where, again, a group like this is really, really, truly important, and because this really highlights those disparities and those inequalities that exist out there. A story that I hear over and over again that destroys me is when, again, a young man goes into an emergency room who knows his disease, who's been taking care of himself, who's in college trying to get to his class, trying to make sure that he gets his pain controlled so he can study for his test. And he's told by the ER physician, who on her point of view, she's seen 5 different drug addicts come through asking for opiates, and she's got to figure out if it's safe or not to give it to them. But this person comes in, and instead of seeing him as who he is, she sees him as a drug seeker. Again, not intentionally, not in a bad way, but it's one of those things we've got to raise awareness about sickle cell disease from the emergency rooms to the patients, that when they advocate for themselves, that it's not a sign that they're a drug seeker. It's a sign that they know their disease and know what they need to do to get help. and that they are the experts. So we need to be able to open that conversation. Once we can get that, right? And once we can get people involved in that specialty care, then we can start talking about these curative intent therapies. This is where that discussion can occur of whether to think about those risks and benefits of going for a one-time therapy. If you think about a stem cell transplant, you're thinking about taking a year out of somebody's life. You have to have the right donor. You have to have the right people. You have to have the person to take care of your kids if you're going in for yourself, or if you're going in for one child, who's going to take care of the others. What is that going to look like? You're going to be, it takes 2 or 3 months to prepare. It's 6 to 8 weeks in the hospital. And then after that, you still got to keep coming back. And you've got to be so adherent with those medications to make those transplants safe. So you're talking about a long-term commitment of about a year where everybody in that family group is going to be disrupted. Big deal. And then on top of that, you know, if we do chemotherapy, if we do radiation, we're going to put your fertility at risks. Is this really worth it for me? And for some people, it's going to be worth it. And for some people, it's not at that time. But that conversation, to have that happen, to understand what is the disease going to look like in the future versus what does it look like post-transplant in the future, that needs to happen. And that needs to happen at the hematologist. And then it needs to happen at the transplant center as well. We need to also develop transplant centers that have expertise in sickle cell disease, who understand this is not somebody who's dying of cancer in the next 3 months. This is not a life or death situation this second. It's still a life or death situation nonetheless, but not this second. So planning around it for their family, what they need to do, is still a viable option to do this. So then we take that to the next step of what can we do, and what are the new things we can think about. And of course, one of the things that I'm working on with an incredible team is thinking about gene therapy for sickle cell disease. Now, the neat thing about gene therapy is that you take somebody's own cells, you bring them into the lab, you modify them. So this is called ex vivo gene therapy for those who want those fancy words. But you take these cells and put them in the lab, and in the lab you modify them. And there's many different ways of doing it. People have heard things like CRISPR-Cas9. What we do here is we do lentiviral vector, which is actually a modified pieces of virus that actually help inject the gene of choice into the cell. You wash out those cells, you check them for safety and quality, then you actually put them back in the patient. Now, the other thing that the patient needs to undergo, unfortunately, is still they have to undergo chemotherapy, because you have to make space. The way we think about it is making space. So it's not necessarily physical space. It's the idea of giving chemotherapy to give a survival advantage to those cells that are coming in that have not seen chemotherapy, so they can engraft and they can grow into all the blood cells, including those modified red blood cells that don't sickle. So there's different ways of doing this. And what we're finding out now is that we can do it. The efficacy is there. So in the bluebird trials, we have done about 40 patients. In our most recent group of 25 patients, we're really seeing that they're not having vaso-occlusive events. They're not having these pain crises. They're able to move and get things going on with their lives. One of the things that I really think our team is doing really well is that we're looking not just at those times of hospitalizations. We're not just looking at those lab values and what the hemoglobin is. We're actually looking to see what the impact is on the person's life. So we're looking at quality of life. We're doing exit interviews to see what that process is like and see how it affects them before and after. One of the things I'm hopeful for, and one of the things I want to make happen, is with all the other current medicines that are out there, including transfusions, you're making somebody with sickle cell disease going from sick to not sick. But hopefully with a transplant or with gene therapy, we can really get them to healthy. So that goal, and that's what I'm trying to figure out, of how can we measure that in a way to make it clear that this is something that is useful and right for people, right? Because if it's not right, you don't want to go through all this and change it for a different disease. That's not okay. So the whole thing is to make this better. So one of the things that does happen is that as we think about sickle cell disease over a long lifetime, there's very few studies that actually look at sickle cell disease for a whole life. There's plenty of cross-sectional studies. When we look at these mortality studies and things like that, they'll say, okay, the population right now, this is how many who are living, here's how many who are not, here's how many who are suffering, so they have these cross-sectional. But for sickle cell disease, it really is a journey over time, and you have to look at that individual person and their experience to help figure out what's going to happen for the future. And no prediction's perfect. As we know in medicine, Nothing is always perfect. So it's this looking at this over time. So what we're discovering is one of the things that we found in our studies is that 2 of our patients from the very first group of patients that we did, what happened to them is they developed an acute myelogenous leukemia. And that has been one of the concerns. Is it that the gene therapy did it? Did this vector, this viral vector that we did it cause it? And our scientists did a lot of really good work, and in about 7 different ways have really shown that there's no way that this vector inserted in a gene that caused the leukemia. And again, we share this with the FDA. We've shared it with our investigators. We've shared it with our data monitoring safety, because you know what? We want to make sure anybody who chooses to come into one of our trials is as safe as possible. So we held the trial as soon as we found out that this was happening. We've had it on hold. And 2 weeks after we suspended the trial, the FDA actually put us on clinical hold because they agreed with us. And then as we've come through, we just found out earlier last week that the FDA feels like they've got enough information about these cases to lift the hold and allow the clinical trials to resume. So the final piece that I want to say about all this is really to think ahead with gene therapy. It's still something that's experimental. It's still something that we know a lot more than we did 5 years ago. There's still a lot more to learn, especially in the long term. And this is where we want to make sure we're having an open conversation with all of our various people who are involved, from policymakers to our patients, to our families, to our physicians, to make sure that we have a clear understanding, and also to get ideas of how we should actually address all of these questions, because they're all very, very important. The one other piece that people are asking, I think I've heard somewhere in the questions, is I heard gene therapy is going to be hard to access. It's only going to be in a few places, and it's going to be wicked expensive. And so how are we thinking about that? Those are great questions. And I can tell you, we are looking for those answers. Don't say we have them yet, but really got some cool ideas of ways to think about it that I'd be happy to discuss if anybody wants to ask the question. So I think that's what I have to say in a nutshell.
Thanks for that, Anju. I think you really set the context for our discussion this afternoon. I just want to leave a reminder for all of our participants that we really do want to make this a very engaging conversation. So if you have any questions that you'd like us to address during today's webinar, please feel free to add those to the Q&A section of the webinar, and we will ask those questions for you. And so I want to kick things off with some, out-of-pocket questions that we had as we were thinking about today's conversation. So Anju, can you explain the potential benefits of gene therapy for individuals with sickle cell disease? I know you highlighted, that individuals indicated that they have less pain crises. But what are the positive impacts it has on their lives, their family lives, society, et cetera, as individuals can get access to gene therapy?
So that's a really good question. So there's so many thoughts about this, right? So the first thing that we want to make sure that we addressed is that pain so bad that it brings you in the hospital, right? So that's the first thing that we addressed. And that's the first thing that we've really shown a big difference. So in the 25 patients that we've done that have been more than 6 months out, none of them have had to go to the hospital for a vaso-occlusive crisis. So for any, and these are folks that had gone at least 4 times in the previous 2 years prior to consenting for therapy, that they were able to do that. So yes, I do think it has a very strong impact on those. We also went back in this study and looked back to see about other VOEs that didn't necessarily require admission, but might have required medical attention. And when we found that out, same thing, that there was many people who would go in for pain crises, and afterwards that we don't see any. So the next step is then, as far as pain's concerned, how much does it interfere with your daily life? And how bad is it? So that's an assessment of quality of life. And we're seeing decreases in that assessment from the quality of life assessment as well across the board. Well, I should say across the board. From the 10 patients that we have that data from right now, because we're still actively collecting that data. So there is some clear signs that pain is helpful. Well, pain is helped. With the other things that we can think about is really with how does it affect everything else? So there's different pieces of that. From the impact of life, well, if you don't have unexpected pain, you can show up to your job every day. If you don't have to expect pain tomorrow, you can plan for tomorrow. So I think there's a lot of those things that I can't answer because we're asking those questions, but nobody's really asked that after the fact. I should take that back. There's one study that's out there that was done by Dr. Krishnamurthy on patients post-transplant, where they were trying to feel about how well they did or didn't do post-transplant. And for patients that did not get graft versus host disease or basically went through, they don't think about having sickle cell disease anymore. It's not part of their planning. They don't think about scheduling a ride versus walking somewhere because of pain. It's pretty deep that way as well. Now, the other question that's underlying that I don't know the answer to, and that we are looking for that answer, we're looking for it, but we stop a lot of the cell breakdown from sickle cell disease with this method. How much? More than 75%. We don't have a fixed number because depending on how you measure it, it's different things. But is that enough? Is that enough to completely, that we stopped enough sickling that it's not clinically relevant? Have we stopped enough hemolysis that it's not clinically relevant? That the body's own mechanisms can scavenge and take care of all those remnants? That's still being determined, right? And that's going to take years to find that answer, because what do we see with vasculopathy? So neurovasculopathy, we could talk about silent infarcts. Have we stopped those? Well, how long do you wait to prove that you stopped it? If you see progression over a period of years. If we're seeing renal dysfunction, how long do we wait to say, well, no, see, look, we took care of it forever. It's going to be hard to tell, and it's going to take some time. So that other portion of things. And then the other impact, of course, the concern that I have is this idea of, do you want to make a family of your own? And with the clinical trials, we've been offering fertility preservation. And it'll be interesting to see how many people access that fertility preservation or need it afterwards. And how many of those who've accessed successfully have children. Again, that's something that's not going to happen overnight. It's something we're going to learn in the next few years. So excellent question. I don't have the answer. We're looking for it. If you got other ideas on what we can do, please let me know.
So when I was giving my introductory remarks, I mentioned several of the adult complications in sickle cell disease, and I know the study is ongoing. But have you seen any changes in individuals who've had acute chest syndrome historically not have it after gene therapy?
So when we talk about vaso-occlusive events, that includes pain crises, and the vast majority are pain crises, but it also includes acute chest.
Okay.
So for those that had acute chest before, we're not seeing any acute chest or any VOEs after that. Good
Great.
question.
And then you had a number of statements in there, and I know what they mean, but I want to make sure our audience knows. So fertility preservation, can you talk about why that's relevant, especially given, the conditioning and things that happen as part of the treatment? And also, as you're clarifying that, a lot of conversation in the community very early on when gene therapy was first talked about and introduced, really had to get down to explaining to a lay audience the difference between somatic and germline, and what does that actually mean for the hereditary component of sickle cell disease.
So let me address that second point first, because in my mind, the easiest way to explain that is that we're not actually injecting the gene therapy into the body. So we're not actually fixing the genes for everything, including those to the sperm and the eggs. The only genes we affect are the ones that we take out to the lab and affect. And those are the hematopoietic stem cells, or stem cells that make blood. And so when we reinfuse those cells, they're the only things that are modified. So when you reinfuse the cells, everything, it's your blood cells are the ones that have been altered. Everything else still has SS or SC or S beta 0 or whichever, whatever genetics that you were born with are still the ones. And those are the genes that you will pass on to your children. So it's something that, again, when we want to talk somatic, we could talk germline, we could talk all that, but it's really it's more basic than that. The only cells that are affected by gene therapy or changed are the ones that matter the most So you can express, you could have sickle gene in all your cells. The only place where it matters is where the gene is actually made into a protein, and that's in those blood cells. So those are the cells that we repair. So again, I would like to think of this as a repair of a specific organ system instead of the whole body. Yeah, I'm not going to fix anything in anybody else. I mean, everybody's got pieces of them that make them unique and beautiful. We don't want to be changing anything else in anybody. So then the fertility preservation, why is that important? So we use the current conditioning regimen. So we had that thing that we need to make space in the bone marrow for the new cells to come in. Right now is chemotherapy. And we've learned the hard way that you really do need to give that high dose chemotherapy to make enough space for those other cells to come in. And when you do that, any cells that are rapidly dividing are the ones that may be affected. And those include fertility cells. So that being the case, actually, it's kind of interesting. In women, where our eggs go into meiosis and they actually do their dividing in infancy, and they're all formed and ready to go after infancy. So actually, women's fertility is a little more hardy as far as the actual eggs themselves. But what happens is all the hormones that trigger the eggs to come and go into normal menses and all those kind of things can be affected by that chemotherapy. So sometimes there's a need for fertility assist. And again, to make sure those eggs stay safe, many people will opt to taking those eggs out and going on with your treatment. So that's an idea between female fertility preservation. With men, sperm is always dividing all the time. So chemotherapy is really, really difficult on those on sperm cells. So with those, luckily for guys, more so than girls, it's much easier to extract sperm and freeze it and save it for future use. So that's where, again, that's one of the things that you can do for fertility preservation. Now, the question that also rises that we don't know the answer to. We know that fertility is going to be impacted somewhat by using busulfan as our chemotherapy agent, but it hasn't been used out as a single agent in many places. So it's considered a reduced intensity conditioning if you were to use it in the transplant world. So there is a chance that fertility is maintained. It's just we don't know how good of a chance it is. I don't know if it's just 5%, and I don't know if it's 50%. So it's one of those things that I keep in mind that people may not need that fertility assist. We just don't know at this time. So at this time, as part of the study, we are allowing and supporting and financially supporting fertility preservation until that we understand what that risk truly is.
Great. And in your earlier remarks, you mentioned graft versus host disease. I'm not sure if all of our participants are aware. Can you talk a little bit about that and why that's not a challenge when you're talking about gene therapy?
Thank you for that question. And sorry to switch into medicalese. Try very hard not to, but I do it every so often. So if you think about the graft is whatever you're going to put into somebody, right? And the host is the person that you're putting something in. So if you think about a allogeneic transplant, so if you're putting somebody else's marrow into somebody, that marrow comes with its own immune system. It already knows what it's supposed to be killing. So when it comes into the host, it may recognize the host as not being part of itself. So that incoming marrow can attack that host.
Like the body's defense system.
Right. So, and by the way, it can happen the other way around. If it happens where the host says, I'm not taking that graft, that's host versus graft disease is sometimes called graft failure because the host can kill off that graft. So this idea of what you're trying to do is to strike a balance between these two immune systems. And usually what we do is we calm them down until they learn to play nice together. And when they play nice together, it's not an issue after that. Now, the closer the match is, so if you've got a fully related matched donor, so be it a sibling or a parent, more commonly a sibling, graft versus host disease risk is pretty low. It happens, but it's really, really low. But you can kind of extrapolate that from somebody who has their own cells that you're modifying just a gene and then putting those same cells back. You really don't have host versus host disease. It's really not a thing. So you should not have a graft versus host disease in that. So it's really not been a concern for our studies or for any gene therapy studies to date. but you never know. Bodies find a way of doing weird things. And if it occurs, we'll have to go find that answer too.
Great, thanks for that. So just a reminder, everyone, if you have any questions for Andrew and myself, please do use the Q&A. So I'm going to go to the first participant question, and it's a more general question. What do you suggest for international travel on a plane for a patient with SS disease, a 10 to 12-year-old child, a long 12-hour flight, or breaking it up into shorter flights?
It's a great question. LaTasha, you want to answer that one? As I'm here
I
as a
think it's a
representative of
case by
Bluebird.
case, but I think of the pandemic right now. So I myself is a healthy AA. So I found out I was AA, even though I have a family history of sickle cell disease and several cousins with SS and several with trait. I myself, as a healthy individual, fairly healthy 40-year-old, have not traveled by plane or by train or any close, types of environments during this pandemic. So I'm not sure if that particular question was aimed at during the pandemic or in general. I think right now for individuals who do have some form of a chronic disease, especially sickle cell, where you're more susceptible to infection and challenges, especially since this is SARS-CoV-2 is a respiratory illness. Subjecting a child, I wouldn't recommend, but I'm also not a medical professional.
So again, and I can't give medical advice because I'm here today wearing my Bluebird hat. However, there is a resource on scdaa.org. They have specific guidelines and where to get information, both for travel with sickle cell disease, as well as COVID and sickle cell disease, and how to get the COVID vaccine if you have sickle cell disease. So there's some good guidance there that might be a good resource for you.
And I've placed the SCDAA link into the chat for those of you. And if you go into their page on sickle cell disease, it has information for patients and families. The other thing that individual wanted, or actually another participant asked, is, are there any data on patients on hydroxyurea with SS and how they've done specifically in this era of COVID? I'll start that answer. There's a really great team that's working on a COVID and SCD index, and I'll put that into the chat. But I think it's the group out of Wisconsin. Am I correct with that, Andrea?
Yep. So they're working a lot more on the actual COVID. What's the impact of COVID on SS disease, and they've actually created an international registry to look at that. So that is a phenomenal resource. Again, that scda.org does have guidance on sickle cell disease and hydroxyurea, as well as whether or not to receive the vaccine. That, by the way, your question, whoever this answers this, beautifully scientific. There are people who are looking at that exact question. And overall, I have a feeling the answer is going to be that it's unknown, but they're looking into it.
Yeah, definitely. So Dr. Julie Panapinto's group, I placed the link for COVID sicklecell.org, and that's the link to the Secure Sickle Cell Disease Registry, which is surveillance epidemiology of coronavirus under research exclusion. And this particular registry, medical providers can go in and log their cases of their patients with sickle cell disease. They have a generalized case report form, and they update and provide a kind of a dashboard. And it's not limited to the US, so you can actually see some of the updates of the data periodically. I think it's every few days. But so far, there's 784 cases that have been reported. The average age of those individuals is 22 years of age. I don't see, I'm kind of scanning it, and that's why I keep looking away because I have two screens open. I don't see any information currently, but I'll keep, oh, actually there is. So I will share my screen to just highlight that to show this participant where to look. But here, are you able to see the screen, Anju?
Mm-hmm.
Okay. So that screen isn't touchscreen, so I have to move my thing. But this is the Secure SCD registry. If you go to updates and data, you'll be able to see the data presented. And down here at the bottom, they do cover hydroxyurea um, in several areas. So home medication, how many individuals were utilizing it and still receive or still acquired COVID. And then also here, the patient's ages broke down by the use of hydroxyurea, NSAIDs, or other transfusion and other types of treatment. So I just thought that was helpful to share with everyone based on the question we received. Next question we have is going back to some of the questions that I thought of to ask you today. How or will Bluebird as an or the industry really ensure access to these types of presumably expensive gene therapy treatments for individuals with sickle cell disease, and what can manufacturers do to ensure equitable access to these new technologies? I know that's a loaded question. But it's one that's, really on the mind of many individuals.
Well, I think so the answer is we don't have an answer yet, right? But I think the way to get to that answer is the discussions that we're doing today, right? And we need to bring our various stakeholders into play, right? So it's not just the payer, it's not just the industry. Matter of fact, we're probably the least affected of those. It's really the patient, the physician, the folks that are working in the fields who can really see what needs to happen. We need to have the input of everybody of how to do this and to figure out how to do it equitably. Again, we need the expertise of folks like who are in this group to say, here's what we've done for other diseases. Here's what we've done to improve things. Here's things that can apply. And here's some things that may not work for you. And I think that that's going to be an important thing. I think that these drugs are going to be expensive. I think that's true. It's not going to be a $5 a month kind of thing. I think but one of the things that I keep in mind is, and what the system is not built to do, and one of the discussions we're happening is this is a one-time thing. The intent is that you don't have to go to do this every 2 to 5 years, and it's not like collagen injection, I shall say. But it's one of those things where it's really a one-time deal. So if we're talking about paying for this once versus a lifetime of medications or transfusions or complications or hospitalizations, thinking about that value for that group of people. And again, if we think about this in terms of a payer as well, is to say, well, gee, I have to think about making sure I have coverage for this person right here with a reasonably rare disease in the US, but it's for one time. If that person stays within my payer group, then I reap the benefits of not having to pay for all these things in the future.
Exactly.
But if it's somebody who's going to be moving in 3 to 5 years, what benefit did I get as a payer in helping prevent it? Somebody else gets benefit, but I don't necessarily get that. So it's interesting to think about. We really do need to have an open discussion and really put each other in each other's shoes to come up with this. But I have great faith that this is the place to do it, and this is the time to do it as well.
And I know in my earlier remarks, I shared that it was over $1 million for individuals living to age 40. But I just went to a healthcare journal and pulled the economic burden of sickle cell disease in the US. And it indicated, using the national prevalence data, which we estimate is around 90 to 100,000 individuals in the US, and an estimated incremental economic burden of sickle cell disease was in excess of $3 billion per year in the US. And that was adjusted to 2015 dollars. So we're in 2021. So that number is quite high. So it's something to keep in mind. Not everyone with sickle cell disease are what we call, the high utilizers. Not everyone has severe disease, but it is a costly disease, costly in terms of financial dollars, but it's also costly on the impact of that individual, their community, and their families. And so I agree with you. A gene therapy approach to ameliorate those symptoms very early on to reduce that burden is something we should think about. And then I'd be remiss not to mention the remarks of our president and CEO of NMQF, Dr. Gary Puckrin, who always talks now about patient risk, right now our US healthcare system is really focused on financial risk. And that really isn't to the betterment of our society and public health as a whole. We really should focus our efforts on patient risk and doing what's right for the patient first. And I think that prevention is key for that. We wouldn't be in the position we are with a number of diseases if we were actually to prioritize and put the patient at the center.
Yes, the idea of healthcare versus sick care. Love it.
Exactly. Next question. It has been said that a medicine is a mirror for racial injustice in our country. It is riddled with racial disparities in everything from research funding, access, life expectancies, and more. There may not be another group of patients more impacted by racism than individuals with sickle cell disease. As a practicing physician, do you find this to be true? And if so, what policies would you hope to see addressed in the near term and or maybe long term that have the biggest impact on improving care for individuals living with sickle cell disease?
Wow.
Your colleague came up with that question. I
I
think it's a
mean,
good one.
it's a fantastic question, right? And you think I'd prepare for an answer for this, but it's such a, so first, does it exist? Oh, hell yes. Excuse my French. It's one of those things where it permeates in a lot of different ways, right? So it's where, and again, for sickle cell disease, even more so than other diseases, because of the need for opiates to treat pain,
Mhm.
it has its own associated stigma that comes along with it, not just, bias because of internal bias or because of out and out racism or anything like that. Just this idea of using an opiate that with a crisis that's out there. And again, I'm not minimizing the crisis. It's actually been shown not to be a crisis in sickle cell disease. That's another story. You'll have to ask somebody else to talk about that in a lot more detail. But it's one of those things where, it's hard to take care of patients with sickle cell disease. And so, especially in an adult practice, and as much as I actually really appreciate my adult colleagues so much, especially those who take an interest in sickle cell and really champion it, because it's a thankless task. Every resource that's out there is, oh, these folks drain the system, they drain the ER, they drain resources. Instead of saying, well, gee, what are the things we could do to actually make this better and make it more interactive, rather than just saying, no, this is not what we need. I think this is it. I think that's where some of the discussion needs to occur, is really at that grassroots level. But we also, again, Gary's right. Of course he's right. Is to really think about this at the systems level, where the system says, it's not so much that you have this disease, but you as a person are you first. Here's your goals, and here's how the disease impacts you, and here's how we can deal with the disease and how it impacts you, rather than defining that person as being the disease itself. So I think if we can do a systemic kind of way where the evil part is not necessarily the person, it's the disease, and can we separate that out? So that's something that I would love to see and do. Now how to do that, I'm doing what I can, right? So this is where I really think it's going to take that. I come back over and over to it. It needs that dialogue, and it needs somebody to champion that dialogue and force that dialogue to happen, because these are really uncomfortable discussions to have, right? These are uncomfortable, not just because of race, but just because a lot of things that are happen are just system based. So you go through check boxes to make something happen. And unfortunately, I really do believe in the world of the electronic medical record, where really people are just letting the data dump into the checkbox to get whatever it is you need, versus actually looking at a person as a whole. I didn't
Thank
answer
you
your
for
question,
that.
did I?
A bit, but I also pasted a link into the chat for all participants. If you'd like more information and discussion around this topic, there was a paper that SCDAA and myself, when I was still at ASH, but I was a professor at George Washington University, and NMQF authored in 2018, I believe it is now, or maybe it was 2019, Reducing Healthcare Disparities, Sickle Cell Disease, a Review, and I placed the link to the free publication there. We have additional question in the Q&A. In general, are there certain criteria to be eligible for gene therapy? such as severity of disease, the complication of disease, and would a relatively stable SS patient on hydroxyurea with very few complications be eligible versus a patient with frequent crises and issues like acute chest and other complications?
What a great question. You didn't plant him or her. I'm sorry.
I did not.
What an excellent question. So, yes, right now you do have to have, for, again, remember, gene therapy is all experimental. There is nothing that's FDA approved yet. So when we talk about looking at a clinical trial, the people that you want to get enroll in a clinical trial are the ones that are most likely to get benefit for the amount of risk that you're putting them under going into this unknown and chemotherapy, right? So when we think about who we're going to treat first, the first folks are the ones that have something that we can show that we've made a difference and that are most likely to gain benefit. So those are the ones that with severe sickle cell disease. Now, that being said, there is no such thing as an understanding, by the way. I've talked to, I don't know how many experts of what severe sickle cell disease is. If you talk to 30 different experts, you're going to get 30 different answers on what severe sickle cell disease is. So for our clinical trial protocol, we specifically picked those severe VOEs of those that need hospitalizations because it was really clear that data point. It's very hard to fudge that data. And then that when it comes back out on the other end, we could actually determine what's going on. So we could see that difference and see it clearly. So that was the way that the trial was designed, with the idea being that those who would be eligible for this gene therapy on this clinical trial would be having 4 of these hospitalized SVOEs in a 2-year period. Now, with the future, what does it hold? Because if you think about what the indications are for transplant for sickle cell disease, depending on who you speak to, and this is where there's some inequalities here, is that depending on which expert you speak to, some folks will say, as a hematologist, I tell families on their second visit when they're babies to check all the other kids to see if they're matches, so they know what their options are. Then there's some folks who will also say, no, transplant has too many complications, too many risks, and you might be trading one disease for another. I don't offer it to anybody. So there's a range out there, right? And so one of the indications, though, for transplant could be being at risk for stroke. And because if you're at risk for stroke, you may have a lifelong transfusion regimen. And if you have a lifelong transfusion regimen, then it could be one of those things of that risk might be worth it. So they'll refer folks there. So for our study, we actually excluded people with stroke because we were worried, were we increasing their risk for a restroke? So we didn't use that as an inclusion criteria. It's something I do hope so in the future that we will be able to do that. So this is also a moving target. This is where we are today. It's not necessarily where we are tomorrow.
Andre, this has been a wonderful discussion. We have 1 minute left, and so I'm going to let you make the last remarks. Are there anything as we come into next week in World Sickle Cell Day that you'd like to leave our audience with?
Yeah, keep sickle cell in the forefront. Use it as a highlight of what could possibly happen. 30 years ago, everybody with sickle cell disease was dying at an extremely early age. We have made so much progress, and the biggest milestones we've made have been in comprehensive care and using simple things like education, penicillin prophylaxis, immunizations. Having access to that care from pediatric to death is so important. And this group really needs to focus on how to make sure that healthcare is accessible for all people, not just people of color and not just people with sickle cell disease, but to make sure it goes across everyone, that everybody can do the best that they can and come and join us and be part of this in the future.
Thank you for that. I think my remark would be, let's all strive to conquer SCD. And along those lines, Bluebird, as well as the National Minority Quality Forum, are members of the Sickle Cell Disease Coalition. And I'm going to paste into the chat the link there if you'd like more information on sickle cell disease.
Thank you so much.
Just thanks everybody for joining. Thanks doctors for educating us today. And now that we've part of the Sickle Cell Disease Awareness Day, we have brought more awareness, and hope you do as well. Hope you guys have a good weekend, and we won't see you next week because we actually observe Juneteenth as a holiday at NMQF. So we will see you in 2 weeks. Thanks, guys.
Thank you.